Good morning. Today we will be discussing about subcortical dementia and non-pharmacological management of dementia. So I am Dr. Rohit Balakrishnan, Senior Assistant Department of Psychiatry, Sri Lakshminarayan Institute of Medical Sciences, Pondicherry, which is affiliated to Bharat Institute of Higher Education and Research, Chennai. So what is a subcortical dementia? So dementia is broadly classified into cortical and subcortical based on the initial location of pathological brain changes and or the presenting symptoms. So it is differentiated based on the initial location of the pathological brain changes and or presenting symptoms. So pathologic changes involve primarily the thalamus, basal ganglia, frontostriatal white matter tracts with relative initial sparing of the cerebral cortex. So there will be changes within the subcortical areas, such as the basal ganglia, thalamus, and the frontostriatal, corticostriatal white matter tracts, and there will be initial sparing of the cerebral cortex. So subcortical dementia are characterized by slowness of mental processing, apathy, personality changes, and depression. So memory deficits. Cortical dementia are initially associated with an encoding deficit, while subcortical are typically associated with the retrieval deficits. So there will be a slowness of mental processing, apathy, personality changes, and depression. So memory deficits are typically retrieval deficits in subcortical, whereas in cortical it is encoding deficit. So unlike cortical dementias, aphasia, agnosia, apraxia are less common in the early stages of the subcortical dementias. So this table lists the differences between subcortical and cortical dementias. So let's go one by one. Language, as far as language is concerned, cortical aphasia will be early, and in subcortical there will be no aphasia. And in memory, as I told earlier, there will be impaired retrieval will be more than encoding. And cortical, both recall and recognition, that is retrieval and encoding both are impaired. Attention and immediate recall are impaired in both. Visuospatial skills, attention, immediate recall are impaired in both. As far as calculations are present, it will be early in cortical and preserved until late in subcortical. So calculations are early in cortical and preserved until late in subcortical. Executive functioning will be disproportionately affected in subcortical, and the degree of impairment is consistent with other involvement. And the speed of cognitive processing will be early in subcortical and late in cortical. So executive functioning, basically it is function of the frontal lobe. So that will be disproportionately affected in subcortical, disproportionate to the other symptoms, whereas the degree of impairment will be consistent with the others involvement. Regarding the personality, it will be unconcerned in cortical, whereas it will be apathetic and inert in subcortical. So mood, depressed mode in subcortical, whereas it will be euthymic in cortical. And speech, there will be dysarthric speech in subcortical, whereas late speech is affected late in cortical areas. Posture, it will be bowed and extended due to the extrapyramidal effect. The patient will be bowed or extended, whereas it will be upright in cortical. Coordination will be impaired in subcortical because the basal ganglia is basically involved in coordination. Also, the motor speed and control due to the same basal ganglia effects, it will also be slowed down in subcortical, whereas it will be normal in cortical. So adventitious movements like chorea, tremor, tics, dystonia. So these are all something which occurs due to basal ganglia disorders. Like chorea, it is occurring due to caudate nucleus problem, whereas it is characteristically absent in cortical. So like in Creutzfeldt-Jakob disease, it is a myoclonus will be present. Okay, so abstraction will be impaired in both subcortical and cortical. So classification. So these are the basic subcortical dementias. So this includes Parkinson's disease, AIDS dementia, subcortical vascular dementia, progressive supranuclear palsy, Huntington's disease, Wilson's disease, spinocerebellar degeneration, idiopathic basal ganglia calcification. So dementia due to HI. So motor and cognitive impairments ranging from subtle changes to overt dementia. Okay, so occurs in 10% of patients with HIV AIDS. It occurs due to immune dysregulation, which results in increase in pro-inflammatory markers, cytokines, which results in neuronal injury, and also include expression of neurotoxic mononuclear phagocytosis. Okay, so clinically, HIV dementia presents with psychomotor slowing, personality changes, impaired abstract reasoning, problem solving, and memory deficits. And psychosis can occur in later stages. We can see characteristically in HIV dementia that language will be preserved. And motor symptoms include tremor and ataxic gait. Neuroimaging. Generalized white matter degeneration is the hallmark feature with associated loss of basal ganglia and posterior cortical gray matter. So, generalized white matter degeneration is the hallmark. So, in some cases, dementia is due to the effects of accompanying opportunistic lesions of the brain. For example, toxoplasmosis and lymphoma. Dementia due to Parkinson's disease. 30 to 50% develop dementia. Parkinson's patients develop dementia. So, classically, they present with slowed processing speed and also memory loss, mood disorders, and difficulties with abstract thought and reason. Hallucinations, delusions, and behavioral changes are common. So, treatment of motor function. Treatment is actually tricky because dopamine is needed in Parkinson's disease, and dopamine can worsen neuropsychiatric symptoms. So, subcortical vascular dementia. So, subcortical vascular dementia may present with subtle focal signs, including gait disorder, imbalance, and urinary incontinence. So, the lesions may be lacunar infarcts or extensive periventricular white matter changes. These lesions particularly affect the prefrontal subcortical circuit, producing cognitive deficits such as dysexecution syndrome, mental slowing, and reduced ability to set and reach goals. So, memory loss may be minor, and subcortical disease is often associated with depression, emotional ability, and personality changes. The majority of patients will have a slow, insidious onset, similar to the Alzheimer's disease or frontotemporal dementia, while only about 1/3 will have acute onset of deficits. So, Binswanger syndrome. Binswanger syndrome is actually a subcortical vascular encephalopathy. It refers to atherosclerotic changes of the small vessels, which results in a subcortical dementia. So next we will see about Wilson's disease. So Wilson's disease is an autosomal recessive disorder caused by an enzymatic defect in the copper metabolism. So resulting in a toxic buildup of copper in the brain and also in the liver also. So it is due to the deficiencies of ATP7B, which is a copper transporting channel, which transports copper from the gallbladder to the blood. So when that gets arrested, so there will be a toxic buildup in the liver, and also as the same channels are present in the brain also, so there will be toxic buildup in the brain also. So the clinical course is characterized by dementia associated with neuropsychiatric symptoms and motor changes. So dementia is due to Huntington's disease. So it is due to chromosome 4, IT15 gene. It is present in chromosome 4 that causes Huntington's disease. So it is a rare motor disorder characterized by involuntary dance-like movements, that is choreo, and lack of coordination, that is ataxia. So it's an autosomal dominant disease transmitted by mutation on chromosome 4. This mutation results in an altered form of HTT protein, which causes neuronal cell death, primarily in the caudate nucleus and frontal lobes. Besides the motor signs, patients may also develop personality changes, depression, blunting of affect, and aggressive compulsive behavior. So cognitive changes include psychomotor slowing, impaired executive functioning, and memory deficits. Currently, there are no effective therapies, although antidepressants and sedatives can be used for associated mood disorders. Huntington's disease is inevitably fatal. So, treatment approaches to dementia. So, what are all the strategies and techniques for cognitive rehabilitation? So, before we go, we can just go through some of the main points in subcortical dementia. So, subcortical dementia is characterized by impaired recall, and executive functions will be disproportionately affected, and speed of cognitive processing will be affected early, and personality changes will occur. That is, the person might get apathetic or inert, and mood changes like depression and speech will be dysarthric speech, and posture due to the extrapyramidal symptoms, bored or extended. So coordination is also impaired, and coordination and motor speed and control is also impaired. So these are the characteristic features of subcortical dementias. Okay, and so okay. Now going to the treatment approaches to dementia. So treatment can be pharmacological and non-pharmacological. So pharmacological treatment, we usually use acetylcholinesterase inhibitors. And also NMDA receptor antagonist. So for mild to moderate dementia, we first start with donepezil, that is an acetylcholinesterase inhibitors. That is at 5 mg we start, and we can increase up to 10 mg. For moderate to severe dementia, and also any dementia with behavioral disturbances, we can start with memantine. So we can start that also initially at 5 mg, and we can increase up to 10 mg. So that being done, we need to focus on the other issues of cognitive rehabilitations, about the caregiver burden, etc. So let's go one by one regarding that. So strategies and techniques for cognitive rehabilitation. So goal identification. Intervention can focus either on direct real life everyday situation or on more general rehabilitative services. So guiding principles include to implement that has to be included throughout the sessions. So that includes effort processing. So more effort the patient makes to retrieve the correct answer, the better. And dual cognitive support to teach strategies that helps in both encoding and retrieval. And errorless learning, instructional technique that reduces or eliminates errors during learning. So the three guiding principles is patient should put effort to retrieve the information, to retrieve the correct answer. So the more effort the patient puts, the better it is. And dual cognitive support to teach strategies that helps in both encoding and retrieval. And errorless learning, instructional techniques that reduce or eliminates errors during learning. So we can teach them recall strategies like mnemonics, queuing, chunking, method of loci, like items to be remembered are associated with specific physical location in spaced retrieval. So spaced retrieval is we will ask, we will teach a patient something, and we will ask them to repeat it now, and we will give a time back, time wherein we after which we will ask the patient again for the same retrieval, same answer, and the patient has to retrieve again. So that is the spaced retrieval. So method of loci. So specific physical locations are meant for uh, a specific thing. Specific physical locations are meant for specific items. So the items are to be remembered according to their specific physical locations. And mnemonics are self-explanatory. And queuing and chunking. Chunking is whatever is similar, we will chunk together. So that is also a recall strategy. And specific interventions include face name recall, number recall, story recall, list or object recall, procedural memory, fluency training, and semantic capacity. So semantic knowledge includes anything that has facts in it, like who is the president of India, who is the prime minister of India. So that is a semantic knowledge. So procedural is whatever the cerebellum does, whatever we were like riding a bicycle. So whatever has a skill in it. So procedural memory. So that's where procedural memory comes into play. So additional support can be given using memory aids, environmental adaptation, relaxation. So planning memory remediation. So first is an assessment as always. So assessments of memory impairment that includes neuropsychological assessment and assessment of functional consequences of memory impairment. That is a prospective and retrospective memory questionnaire, and assessment of use of memory aids and strategies. So to understand the past assessment, past experience. So first we'll do a neuropsychological assessment, and then there will be a memory questionnaire And then we will have to understand the past experiences which the patient had, based on which we can plan the future routine. Therapy. So assessment of awareness of memory deficits. Uh, so that is the Clare model, Crossan and colleagues. It has three major divisions: intellectual, emergent, and anticipatory. So intellectual, knowing there is an impairment, but not necessarily recognizing the problems as they occur. So in the intellectual thing, the patient knows that there is an impairment, that he or she has an impairment, but he is not necessarily recognizing the problems as they occur. And the second one is an emergent, online awareness of the problems as they occur. So anticipatory, using the knowledge of deficits to anticipate problems and taking steps to prevent problem occur. So these are the three things based on recognition of the problems, the impairment, knowledge of the impairment, and recognizing the problems. So one is, so all the three, the patient knows that he has an impairment. So in the intellectual, the patient will be necessarily recognizing the problem. The patient will not be able to recognize the problems as they occur, even though he or she knows that there is an impairment. In emergent, the online awareness of the problems, a patient knows as they occur. And anticipatory, the patient knows he has deficits and he anticipates problems and he takes steps to prevent problem occurring. So planning, memory, remediation, treatment approaches. So interventions must take account of several factors, including form and severity of memory impairment, presence or absence of additional cognitive impairment, and an awareness of deficit. So with regard to the form of impairment, major distinction is between primary working memory and secondary long-term memory. So remediation of the primary working memory. Intervention for working memory problems is done as a part of a more comprehensive cognitive remediation program. It has limited evidence regarding its effectiveness. So, under the remediation of the primary or working memory, the intervention for working memory problem is done as a part of a more comprehensive cognitive remediation program, but it has little evidence. So, remediation of the secondary long-term memory problems. So, are there contributory factors? So, we must consider whether a range of other factors are contributing to the functional disability. If so, then one should include the intervention for these factors in the treatment plan. So this includes treatment of mood disorders, sleep disorders, management of fatigue and pain, or adjustment of medications where possible. So in the remediation of the secondary or long-term memory problems, we must consider whether a range of other factors are contributing to the functional disability rather than the memory itself. So such includes the treatment of mood disorders, sleep disorders, management of fatigue and pain, or adjustment of medication where possible. So in some patients, memory problems will be secondary to impaired attention and concentration. And if this is the case, then intervention to address these problems should be considered. And also we should rule out, so basically they are saying we should rule out pseudo-dementia. So pseudo-dementia presents like patient complaints of memory deficits, but they wouldn't be having a memory deficit, but that could be secondary to their depressed mood. So the second thing that we need to look for is the person aware of the problem. So if there is no awareness, then it is important to consider means of improving awareness before pressing on with specific remediation strategies. Often it is more complex. Use of education and self-other monitoring of memory slips in conjunction with feedback can help. So working with patients in a group format can contribute to improving awareness. So if awareness cannot be improved, then the strategy of modifying the environment to use memory demands on the patient must be considered. So environmental modification includes the use of prominent signs or labeling to support orientation in the physical environment, and also like switching the lights on during the daytime. Also, patient would get oriented that when is day and when is night. And also establishing a very daily fixed routines can also help develop behavioral habits. So for mild problem strategies, So in the context of mild memory impairment, then memory strategy training is recommended. So for example, external aids, using diaries, notebooks, watches, mobile phones, PDAs, okay, and external self-talk, and internal strategies like visual imagery, association, number word mnemonics, space retrieval. As I had told earlier, association is nothing but a chunking of related things together and using visual imagery like what has been explained earlier by using placards or something that can be used to identify where the toilet is and etc. And spaced retrieval program. So also we can consider use of memory group format. So moderate to severe. Identify priority everyday remembering needs and select strategy to reflect. So example, training in the use of specific external aids. Example, Dorset box, memo board, diary, or checklist for specific tasks. So externally directed assistive device. Example, NeuroPage. And supported learning of specific information. Example, errorless learning for learning names, routines, and procedures. Modifications to the environment. And consider use of memory group format with additional 1:1 support. So moving on to the psychosocial issues. So educating patients and families about dementia and the course and what to expect at each stage is important for general treatment and anticipatory planning. So maintaining safety is the primary important thing. So ensuring adequate supervision and support, connecting patients and their families with community supports and resources, provide support for caregivers, and encouraging legal and financial planning all play an important role in the management of the patient with dementia. So, psychotherapy. Psychotherapy may be useful in the early stages of dementia before short-term memory is to impact. The most promising are the reminiscence therapy and the supportive psychotherapy. So, supportive psychotherapy is basically something which wherein we change the environment and not the patient. So, we use it in patients who are not who are very poorly motivated and very poor coping skills, and one who's not able to understand what it is like the demented patient. So we change the environment around them rather than the patient themselves. So that is a supportive psychotherapy. And reminiscence therapy allows patients to recall and relive past life events, stimulating memory and mood within the context of their life history. So this therapy has resulted in modest short-term gains in moods, behavior, and cognition in the confused, so-called confused elderly patients. So we just make them recall and relive their past life experiences. So that will stimulate their memory and mood within the context of their life history. So there will be a modest gain in the mood, behavior, and cognition in the confused elderly persons during the reminiscence therapy. So the focus of supportive psychotherapy in the early stages of dementia is adjusting to the illness and the losses inherent with it. So there is little evidence supporting its efficacy. So next we are moving on to behavioral therapy. So behavioral treatments identify consequences of problem behaviors and then affect changes in the environment to alter the behavior have been shown to be beneficial. For example, scheduled toileting can reduce the frequency of urinary incontinence. So behavioral treatments basically identify the consequences of problem behaviors, then affect changes in the environment to alter the behaviors that have been shown to be beneficial. So behavioral management training programs for caregivers have shown modest reductions in problem behaviors. Okay, now about cognitive retrain. So cognitive skills training exercises focused on maintaining specific cognitive skills and reality orientation have limited support as the benefit is generally short-lived. So these approaches may actually be detrimental to patients as these might lead to anger, frustration, and depression in patients and in caregivers. So stimulation-oriented therapies. So they include recreational therapy, like using crafts, games, art therapies, by using music therapy, dance therapy, art therapy, and pet therapy. aromatherapy, so multisensory stimulation, simulated presence, and exercise. So these are all stimulated oriented therapies that are used for the treatment, the non-pharmacological treatment of dementia. So despite the lack of convincing evidence for these modalities, their inclusion in a multimodal treatment plan for patients with dementia is humane and also makes sense. So education. So providing education to patients and their families about dementia, its course and consequences and treatment is important in helping them to plan for future disability. Books and community agencies are available to help guide families through the caregiving process. So expressed emotions. So that is an important factor which can depend the disease burden which the patient can have. So expressed emotions are something which needs to be taken care of. So for that, the family needs to be educated about the disease, about the issue with the disease, and uh, how it can be handled in the best way possible. So education is the key to reduce expressed emotions. Legal and financial plan. So patients and their family should be encouraged to pursue legal planning such as living wills. So to write a will, the patient should know what the what the will is about, the property that he is having, the people that he is people that he is going to give to, the people who is their hire, who are legally who can get the property. So the patient should have this idea, only then he can write a will. So in a demented patient, there will be a gradual deterioration wherein patient loses all these functioning. So all these things should be taken care of earlier. Power of attorney and guardianship for when they no longer have the capacity to make decisions for themselves. So, there will be a state where they cannot make decisions for themselves. So at that time, so the patient has to plan for a power of attorney and guardianship. So uh, when he is still capable of making decisions. So maintaining safety, that is a very important thing in a demented patient. So patients with dementia are at greater risk for accidents. So forgetting to turn off the stove while cooking can lead to fires, and forgetting to lock doors can increase the risk of burglary. Or a patient addresses threats to patient safety is necessary to protect patients from inadvertently harming themselves or others. Driving. So patients should be advised to limit their driving in mild stages or at the first signs of impaired driving ability or accidents, and to stop driving when they are in the moderate stages of dementia. So driving restrictions can be very difficult for patients to accept due to the loss of independence and dependency on others for transportation needs. So families often need to get involved to enforce these restrictions. Caregiver support. So, as I had mentioned earlier, so as demented patients decline, they become more dependent and require help with more activities of daily living. So, caregiving is physically and emotionally demanding. So, patients with low socioeconomic status will have a financial burden because the patient wouldn't be earning, and that would take a toll. Treating them would take a toll in their financial situation also. So because the patient has less ability to communicate and frequently exhibits inappropriate and difficult behaviors. So, caregivers are at risk of physical injury by the patient during the periods of agitation and related to acting on delusional beliefs. So, demented patients may usually have delusional persecution, wherein they feel that somebody might be stealing, might be robbing things from them. So they would have that delusional beliefs and they may act upon it, leading to physical injury of their caretakers. So caregivers also frequently become isolated from their social supports as patient can no longer engage in their usual social functions. So the lack of social support leading to depression can also impair caregivers' ability to provide adequate and appropriate care and is a risk factor for abuse and neglect of the demented patient. So interventions shown to reduce caregiver burden include psychoeducation about dementia, and comprehensive support, including individual and family counseling and support groups. Abuse and neglect. The strains of caregiving are a risk factor for caregivers to abuse those in their care. So, in addition, due to demented patients' poor memory and inability to recall or solve problems, they may be less likely to report abuse, or the veracity of their reports may be questioned. So, end of life issues. So, dementia is a terminal illness. So, when dementia progresses to this stage, families will be faced with decisions regarding many life prolonging interventions, including placement of feeding tubes and treatment of emergent infections. So, alternatively, involvement of hospice or palliative care services can be considered. So, herewith I'm ending my presentation. So, these are my references. Thank you.